So let us look at nephroprotection by drugs in the hypertension management. Next slide. As I said, the most important thing is RAS blockade. That means either the prils or the sartans. So there's the usual enalapril as the first one, and losartan as the first one. From the other side, the ARBs, and now there's a whole bunch of them. But I'm not here today to talk about them. They all are good. They are the primary drug. They are the standard of care, particularly if there is a lot of proteinuria. On the other hand, if there's not much proteinuria, it's less than it's A1, you may use even other drugs to start with. But there are major problems with these. Next. So the targets would be to lower the blood pressure and reduce the proteinuria. Now remember, I put number 1 as lowering pressure. Number 2 as reduction of proteinuria. Because if you don't get the pressure down to 120/70, which is the latest recommendation for our guidelines from our societies and from all the new societies, the important thing is get the blood pressure down first by hook or by crook, and then hope that you get better target target value by reducing the by reducing the proteinuria. So always lowering pressure is priority. Thirdly, retarding the progression of renal disease, and fourthly, reducing the cardiovascular risk. But now today I would say that number 4 is before number 3. So if I can't, and because the cardiovascular risk comes much earlier than the renal disease, so the patient is creatinine of 3 and gets a heart attack, he will never go to the stage of dialysis or transplant. He'll die, or he'll have such a bad heart that he'll have a very poor life on transplant, may not get a transplant. So the targets are as follows with RAS blockade or any of the drug therapies. Next slide. And these are the pharmacological effects. They reduce the blood pressure by vasodilatation of the efferent arteriole and reduce the intraglomerular pressure. They reduce the proteinuria. They produce natriuretics, natriuresis. So many patients will tell you, I want to go and pass urine. That acts because they block the aldosterone by blocking the renin-angiotensin system. That's why the RAAS blockade is there. And then reduce expression of cytokines and growth factors, reduce macrophage infiltration and myofibroblast proliferation in the interstitium, and that's how they protect the kidneys, by reducing the fibrosis. But you must go early. Next. And then, of course, is the rise in creatinine and hyperkalemia. They're the two major side effects of RAS blockade. And therefore, it is very, very difficult for us to titrate correctly. Next slide, please. And therefore, when these are the safeguards while initiating RAS blockade. You have to rule out bilateral renal artery stenosis because that's a no-no for RAS blockade. Watch the GFR and potassium like a hawk after starting RAS blockers or after every increase in dose. And if there is more than 25% increase in creatinine or reduction in eGFR, then withdraw ARBs and then reintroduce when the creatinine has come back to normal or within its baseline. And situations need review of prescription. You cannot tell the patient come back after 6 months. You just don't know, he may not die within that period. So a frequent renewal of prescription is necessary. Next slide. And the preemptive withdrawal is necessary. If a patient is undergoing volume depleting surgery like cabbage, CABG, or has sick days like a high fever or a flu, or has gastroenteritis, which is any hypovolemic state, acute shock due to hemorrhage, or concomitant use of drugs like NSAIDs, then you have to withdraw these RAS blockade. So these are the circumstances under which you need other drugs. Next slide. So slowing down with ARBs is good, as you see in the upper slide, but there is risk benefit, has to be carefully assessed. You have to watch the creatinine. Better proteinuria suppression than any other drug is with RAS blockade, no doubt about it. Avoid volume depletion, avoid ACE inhibitors and ARBs in combination. Next slide. Next slide, please. Next slide. Here we go. So, but look at this meta-analysis. After getting all the data in hand, and even from my personal experience, I tell you that when I see prescriptions of family doctors and family physicians and internists, there are more prescriptions without ACE-ARBs and less prescriptions with ARBs or ACE inhibitors, which is a crying shame. But the reason is this: the mortality outcomes with calcium channel blockers are better than those with ARBs and ACVs. Why? Next slide, please. So let's take the story of a 27-year-old male nephrotic syndrome, 2.7 gram albuminuria, BP of 160 by 90, and a creatinine of 1.4. The eGFR is 68. The biopsy shows IgA nephropathy with FSGS with 20% fibrosis. IFTA is fibrosis and tubular atrophy. It's a sign of proteinuria having hurt the interstitium. Steroids and mycophenolate have failed to bring about much change. We added an ARB, and then that didn't bring about too much change, so we added cilnidipine. With the ARB, the creatinine came down to 1.8. The GFR reduced to 20%. And next slide. So this is the looking back at the graph, what happened to this patient. Next slide. So he started from A1 and G2. Okay. We first only added RAS blockade. His creatinine actually went up a little bit, eGFR came down, and he came to A2. But when we added CCB, his creatinine actually went up a little bit because we reduced the RAS blockade because of the GFR falling, and the large dose of CCB, and he went to the yellow. So from deep into A3, we brought him into A3, A3, he was deep into A3 with GFR 3A, and now he's in 3B, he's in 3A, but he has actually gone from orange to yellow. So actually, patient is a little upset because the creatinine went up to 1.8, but his proteinuria went to 200 from 1.7. Next slide. So we did a good job on him, but sometimes you have to explain to the patient. So coming back now to the CCBs, the earlier CCBs, which were nifedipine and amlodipine, and this is the dihydropyridines, and the non-dihydropyridines were the diltiazem and verapamil. Now, the non-dihydropyridines are of no great effect on proteinuria, but they are very good for the heart conducting system. They slow down the heart, therefore atrial fibrillation, but they have a negative inotropic effect. They actually reduce the cardiac output. So we don't talk to them, and we don't use this in our CCB armamentarium for CKD. Next slide. So the ideal dihydropyridine CCB is defined as one which is as effective in lowering blood pressure as amlodipine. It has broad spectrum effectiveness, which amlodipine doesn't have. It should have positive effects on kidney and CVS, that is on the proteinuria and on the heart. Can it be combined with other antihypertensives? That is the ideal one. You have difficulty in combining, not good. Can it be tolerated well, even with high doses? And does it give us freedom from the side effects of dihydropyridine, calcium channel blockers of the earlier era? So we have a new era of antihypertensives. Let's look at that now, of the CCB type. Next slide. So the major drawback with both amlodipine and nifedipine was reflex tachycardia. When the vasodilatation takes place, the body throws into action adrenaline, noradrenaline due to vasodilatation, and there's a reflex tachycardia. There is edema, major problem with edema. A film star came and took my consultation. I, in the olden days, wrote for her amlodipine, and sure enough, after 15-20 days, she came back with a stick in her hand wanting to beat me because the feet were swollen, and she went to a big party and they looked at it and say, "Hey, you have kidney disease." Oh my God. Imagine my predicament. She never saw me again. I'm glad she didn't sue me. But this is a huge problem that people, especially in India, wear open toe slippers, etc., and the huge edema burden is there. The renal non-protection, it has no effect on kidneys over and above its blood pressure lowering effect. So up to the point that it brings you down to 130 or 120 also. Amlodipine is good, but it has no effect on proteinuria. In fact, it has no effect on GFR. Next slide. And these are again just reiterated, but the important thing is that these 5 problems, a lot of BP variability. If you take nifedipine, you have to take it 3 to 4 times a day. Otherwise, it doesn't work. Increases kidney damage, increases proteinuria, increases the heart rate, reflex tachycardia, and only BP reduction, no organ protection beyond the point that it lowers the pressure. So this is why we need to look at, next slide, look at other drugs. And then we come that, why is it so? This is an incomplete group of drug, incomplete CCBs. And what are incomplete CCBs? Next slide. This is how they produce proteinuria. If you look at this picture on the right side, you will see this in the skin under the feet, and the shin and the legs. You have this nice conglomerate of capillaries which exactly mimic the glomerulus. And you have on the left side the arteriole, which gives a network of capillaries, and then on the right side you see the venules. And just like the amlodipine, which relaxes only the afferent arteriole, this red capillaries and are part of that system genetically. And the other system, the venous side, does not dilate, so the intraglomerular pressure goes up. Here again, the pressure within these venules goes up, doesn't allow the venous return to go smoothly, and the edema accumulates. So this is a very serious dilated arterioles and not dilated venules give this edema. So you get this capillary pressure causing expulsion of fluid into the surrounding tissues and pedal edema. Next slide. And this is, why does this happen? Let us look at the calcium channels that are available to us. All along blood vessels are these calcium channels which cause ingress of calcium into the vessel and squeezing and constriction of the vessels. So you got the L type, which are universally available in all calcium channel blockers. But there are extra P type, N type, R, and T. And of these, we means the medical community, I don't do any research, but N type, T type are now able to be made to behave by blockage, by drugs. So the blocking effects of L type alone are seen only in nicardipine, nifedipine, and amlodipine. The L and T are blocked by azilnidipine, manidipine, barnidipine, binidipine, and efonidipine. But L and N are blocked very nicely by silnidipine. It's the only one that has a large number of L type, which can block the N type calcium channels. Now, what are the N type calcium channels? Next slide. You see these channels, they are seen on the glomerulus, and you see that the L type is only present on the afferent arteriole, whereas the N is present on both sides, and the T is also present on both sides. So if you can only block the L type, like with amlodipine and with silnit and with nifedipine, then the afferent arteriole will dilate, whereas the efferent will remain the same. And the pressure in the glomerulus will increase. Hydrostatic, simple physics. So the leakage of protein by damage to the podocytes will increase in the glomerulus. On the other hand, if both are dilated, afferent and efferent, in fact, you have a good reduction in the intraglomerular pressure. And this is the mechanism by which silnidipine beats the exclusive calcium channel, L-type calcium channel blocker, amlodipine, which is today's powerful and gold standard as far as calcium channel. So this new group of drugs, and of these, the most useful is the one with the L and N. Now, what's N? Next slide. The nerve endings in the heart, in the kidneys, in the brain, all have sympathetic nerve system fibers. And these are shown on the right. And these nerve endings, the channel that can make them more vascular are the N type. This is sympathetic nerve. The N is for nerve, sympathetic nerve. And they are present on vessels in the heart, in all the blood vessels, in the heart and in the kidney. And if you block these simultaneously with the L type, you get a very good additive effect. Next slide. Next slide. And you see here that if you block it, the calcium channel is blocked from releasing norepinephrine at the N terminal. That green thing, this is the N terminal. And if you block that, then you stop the release of norepinephrine from this terminal. And the norepinephrine is what hurts the blood vessels in the heart and in the kidneys and all over the body. And therefore, it is best to have L and N type blockage rather than only L type.